Welcome back to What the Fertility Season 4. Today we are so excited. We have two very special guests with us, Dr. Edward Tarnawa and Dr. Graham Theisen. Is it Tyson?
That's right, you got it.
Okay,
Yeah.
awesome.
I answered everything, so.
Awesome. Both of these physicians are with PREG, Piedmont Reproductive Endocrinology Group, and we will let them kind of describe what PREG is and where it started. But Dr. Tarnawa is my personal REI, so we actually started this podcast 3 days after my chemical miscarriage with the IVF that I did with Dr. T. So super special. They've really been here through the whole podcast, but let's get started. Dr. Theisen, do you want to share with us a little bit about how you got into reproductive endocrinology and how your personal professional life evolved?
Yeah, absolutely. And any of my patients will know this is something that I talk to them a lot about is that, I got into this way back when because it was something that I knew that I needed to build my family. So I'm gay, I have a husband, and we knew that if we wanted to have biologic kids, it was going to take the work of an REI doc. And so I have been through this process as a patient before. And through a lot of the struggles too. If I took us for our son 3 embryo transfers before we finally had one that worked, and then luckily now we have our daughter worked with gestational carrier, was one and done, right? And so it really sort of showed me that, way back when when I was an OBGYN, that there are a lot of variables that are hard to control, which is I think hard for me and hard for a lot of patients. It's like, I think that we all want to say we want to have things that we control. And we want to say, okay, we had this thing happen. We want to make some kind of change. Sometimes there's not much you change. You have to kind of just keep trying. And so that was a really stressful thing for me, but it was also something that really I have brought with me into my practice because it's very, very personal for me. And I talk to patients all the time about how I sort of have been through those struggles and understand that it's an emotional journey that no one that hasn't dealt with it will ever be able to understand what it's like to deal with infertility or to deal with recurrent pregnancy loss. And so I think that is a extremely important part of the job. I always say sort of my most important job is to help people have babies. The next most important part is to help them know how they got there, and sort of be with them along the way. So, it was something that I always was interested in, even from when I started medical school, and it's primarily because it's something that I always knew that I needed, and I'm so glad to be a part of it, and so glad this field exists because it's why my family exists. So
Same for both of me.
Yeah.
It's just super exciting. And so are you from Charleston? I know you went to MUSC.
So I did go to MUSC. I grew up in Greenville.
Okay.
I grew up in Greenville, went to Clemson, sort of child of the South. Went to MUSC for my grad school and med school. That's where I met my husband. He was at College Charleston, a few years younger than me. We met when I was doing my grad work. So it was like kind of the easiest part of my life. I had done my medical stuff, and so we met, and I was just I was a research assistant and doing some like master's of science things. But compared to med school, it was like, cakewalk.
Yeah.
And so we met. We'd only known each other for a year, and he luckily came with me to Louisville for my residency. But I always said, like, before I'm going to propose, you got to see what real medical life is like. So I waited until like my first, after my intern year to propose. And then of course, it's like 2 guys trying to like plan a wedding. It didn't happen for 5 years.
Oh my gosh,
And it took a little work of our parents to be like, all right, you guys actually have to do this.
Yeah.
Got married, went to Augusta, did some research there. A lot of genetics research was what my sort of specialty was in. Was an OBGYN there for 4 years, 3 years of fellowship for my fertility training, and then here I am now, back to Charleston. Once we found out PREG had an opening, Ryan and I always said that we wanted to get back to Charleston. We always thought it was going to not be until we retired. And then we found out there was this opening. We were so happy to be able to come back.
So exciting. Yeah. Thank you so much for sharing that.
Yeah.
I know. Okay, well, pretty much the same question, but this time to you, Dr. T.
Sure. Well, as I'm sure it's pretty clear, we are very lucky to have Dr. Tyson. Dr. Theisen or Tyson spelled like Theisen, but my path to here, perhaps a bit less momentous than Dr. Tyson's, but I'm from East Texas and went to college in Dallas and med school San Antonio, and I vividly remember being upset that I even had to do the OBGYN rotation as my 3rd year. I was like, I'm gonna be a heart surgeon. Why do I even have to do this? but I loved it. The people I met, the diversity in the field, you can go into oncology if you, maternal fetal medicine is just internal medicine for pregnant women. This field, primary care angles. There's just a lot of ways to go with it. The people I met were fantastic, and that was kind of decision number one, which was a surprise, but that's what life does, right? And my last year in medical school, I did a rotation in REI, and that I met two people who I consider tremendous mentors to this day. Just two of the brightest, most driven, interesting, great doctors I've ever met. They're both REIs in Houston now, but that's where I got my first exposure, and I realized that the pace of advancement was remarkable. The technology was cool, but I also saw it as one of the few areas in medicine where there's a tangible problem that you can definitively move past. You can address it, you can fix it, you can cure it, right? I mean, there's plenty of conditions that are just chronic and you treat it and dabble with it and they just have to live with it. But this you can overcome. And being a small part of an experience that is so gratifying and difficult to get to in most cases,
Yeah,
what was
absolutely.
appealing to me. So that led to that decision. I too had experience at MUSC, again from Texas, but I heard Charleston was fun. And,
Yeah.
and it was.
Yeah.
And that's where I did residency. I met my wife there. Got more exposure to the REI world during residency, but went back to Dallas for fellowship, practiced there for 3 years. But from an early point, we knew, my wife and I did, that we wanted to be back in South Carolina. Um, that led to PREG. I was introduced to that crew. They had started PREG in the upstate of South Carolina, Greenville, the most established practice in this state. But they had expanded into Columbia at that point. They had acquired a practice from a doctor that was retiring. They needed a full timer, and that was me. I didn't know a thing in the world about Columbia except I had driven past it to go to Charlotte. And but that's where we went, and we were very, very happy there. COVID comes along. The last thing I expected to hear was that a practice in Mount Pleasant, Charleston area was going to, the doctor there was going to basically get out of medicine, and reached out to us to see if we'd like to pick up where she left off, and we did. That took PREG into the Low Country, into Mount Pleasant. I'd always said, "Give me right of refusal," and there I was in Mount Pleasant, always with plans to bring it up the road a little bit to where we sit now in Somerville, a rapidly growing suburb, if you will, of Charleston. And we moved the practice here. We've got a full IVF center here in Somerville. In addition to Columbia, to Greenville, we also have offices in Asheville, North Carolina, Spartanburg. And the newest is back down where we started in the Low Country in Mount Pleasant, which has been great to help patients a little bit closer to the coast to get in and out for some of the more simple procedures and appointments, but just to come up here for some of the procedures. So Dr. Tyson and I, we're both in both places, and we love it. We love the Charleston area, and that's a little bit how PREG came to be. And
That's awesome.
I
I'm
guess
so
how I
glad
came
you're
to
not a
be
heart
too.
surgeon.
I know.
I wouldn't have my kiddos.
I'm sure so many people feel the same way. that you
Yeah,
are.
yeah, no, that's awesome. And so PREG, I think it was like, I'm trying to think. So was it 2020 when you guys moved in, or 2019?
It was July of 2020
2020.
Wow.
when we started in Mount Pleasant.
Yeah, because I was with a different clinic, and PREG is my second opinion. It was you guys, I don't know if you still do, but you had just started here, and it was like the free second opinion.
Yeah.
And I remember Dr. Robinson had suggested y'all's van was always out front of our clinic. Like, what is PREG? Like, I thought it was just like this like weird breastfeeding thing or something.
Lovingly called by us the Pregmobile.
And he's like, yeah, have you heard about this PREG place? Maybe because I wasn't happy with the care I was receiving in 2020. And I was like, no, but what can it hurt?
Yeah,
like,
that's
let me
right.
go. And I tell everybody this. I mean, not only was it a free like appointment to come and like sit and have, but you spent an hour with me. And it was exactly what I think a lot of patients expect.
Yeah.
They're thinking that when they finally get that referral to an RE, they're like, okay, I get to go in, I get to tell my story,
Yeah.
I get to kind of ask all these questions. And a lot of the times that's like not what happens.
No.
You go in,
Not at all.
especially like, and I want to hear your experience, but like for my
No.
first experience, I went in, I didn't even see the doctor. I had all these labs drawn, and then like my husband had the semen analysis. We walk in and they're like, oh, here are the results real quick. You probably have, and you know that I don't, but you probably have diminished ovarian reserve and your husband looks perfect. Great.
Yeah.
Like we'll see you later, or
That
you
was
can do
my
IVF.
exact experience. So like, here you go. You can only do IVF. So let's
No-
whenever you're ready, we'll start.
Yeah,
So, like,
no room for questions, no
Nothing.
room to
Yeah.
like, you want to tell your story, right?
Yeah.
And you want to like be heard. And so I came up here, and I actually, at the time you were in that small little Mount Pleasant office. I went and you let me ask like all these crazy questions, and you continue to do that for like the 3 or 4 years that you've kind of helped me through everything. But it was just such a different experience. And I think maybe just quickly, if you guys could even like maybe shoot off like some questions for listeners to ask during that initial
That first
REI
appointment,
appointment.
yeah.
Like, what are things that you should be asking? Because people go in and they're like, I don't even know what to ask them.
Yeah, you just like don't know what you don't know, and you're already like all your emotions are so heightened going into this because obviously no one wanted to have to go to see a specialist to try and get pregnant. Like you wanted to just be able to do it at home. So I feel like going in, people can either just like feel overwhelmed or intimidated and not know what to say.
And if they don't have that expected experience,
Yeah,
right? So
exactly.
they're having
Yeah.
this expectation, and then you walk out with your spouse and you're like, whoa, that
just
was
happened?
what
Yeah,
just happened.
yeah.
Exactly.
What would you suggest? And you being a fertility patient yourself, like what would you suggest?
And
A question or
I was
two
gonna
would
say,
be?
so I mean, I give every time I have a new patient visit, I basically give people a full like lecture on sort of everything that happens, every single thing that we test.
Mhm.
And that kind of goes back to what my sort of goals are: get you pregnant, but 2, how did you get there?
Right.
And so when we start with what is AMH? You know, what does it mean? You know, where's this AMH coming from? Why do we draw on this lab? Why do we do that and do an antral follicle count? Why does it have to be on the 3rd day? Why do I have to get an ultrasound on my period?
Yeah.
Right? Like, why is that? So I like literally, I'm very visual. I'm a very visual learner, and I think it helps me kind of. So I draw a uterus out, I draw the ovaries out, I draw the pituitary out, and we give start with a baseline. So that, because you know what, if you even those of us who are in medicine, if you don't go into infertility, you don't learn about this stuff.
Yeah.
No.
And certainly if you're a patient, unless you are dealing with infertility, you've never had to ask these questions before.
Yeah.
Right? And so my philosophy is, first of all, there really aren't any dumb questions that exist, because I pretty much just assume that this is probably the first time that a person's ever had to ask these questions. And it's extremely emotional and it's extremely sort of nerve-wracking. A lot of times it's been several weeks of waiting for this appointment, not to mention a year usually of trying, and all this time there's all these questions building up and people are starting to, and I always say it kind of hits the most stressful things in a couple's life, right? It's like money, kids, and sex.
Yeah.
All the stress points. And so they're stressed with each other. They're
You hit it on
It's-
the money piece. I forgot about that. Like you
Mhm.
go into that first appointment
Yep.
and they're like, here's what it is. And also, do you want to sign this for 30
Right.
grand?
Right. So I think to answer your question, I think that a really good question is sort of what are we trying to find out here? Like, what can we find out? And I have a lot of people that sort of will ask things like, and now I've kind of tailored what I talk about to what I expect people to ask. People will ask, like, what does this mean? What does AMH mean? Like, I always have people during my little talk say, stop me and say, like, what does this mean?
Yeah.
If I'm going too fast, if I'm using like scientific, like weird jargon that like doesn't have any meaning to
Yeah.
you, please stop me and tell me.
Yeah.
But I remember, when I was going through my IVF process, this was back in Augusta where I was training, and while I was training, I was an OBGYN doing my research. But I knew that I was going into infertility at some point. But Ryan and I, we like started the process. I go in for my, my new patient visit with my future boss, who's going to eventually be my like person that was training me. And even for me, knowing that I'm interested in the field and knowing everything that I know about infertility, it was still overwhelming for me. There's so much information.
Sure.
And what I always tell people when we're going through like an IVF conversation is, we have an hour long when we start. I usually will do an hour long with people to go over IVF. I've actually made like this animation that sort of talks through the whole process, because it's very overwhelming to think, okay, here we are today. We've decided we want to do IVF. How long is it going to be until we could conceivably have a baby?
Mhm.
Yeah.
How long is it going to be till we're doing an embryo transfer? And the timing, it is identifiable. There's ways, there's going to be some ranges, right? So like not everyone's follicles are going to grow at the same rate. There's going to be a little bit of wiggle room here and there. But you can say like, okay, based on where we are right now today, our decision-making processes, we've decided we're going to do this. It's going to take a couple of weeks of birth control pills. Usually for most people, it's 8 to 11 days of medications. And then I sort of go through, then we have like 5 days of embryo growth. And typically speaking, the recommendation these days is to freeze embryos and then let your body get back to normal. And if people have questions about that, I'll explain, well, why do we do freezing for all these embryos now? And, I guess it's a long way of saying there's really no bad questions. Anything, I think that you should feel very comfortable with your doctor asking them, because again, they should understand this is the first time that you're ever having to ask these questions. And more than likely, because we don't talk about infertility when we have it, you don't really, most people haven't had the chance to even talk to their friends about this stuff, right? And so there's really no wrong questions. And going back to kind of your idea with your, your first provider, I say all the time, because we still do the free second opinions. So I see a lot of second opinions.
I love it. I'm like, everybody, they do it. If
And-
you're having any
and
second guess it.
What I always say is this, in the world of infertility, we only have so many tools in our toolbox, right?
Mhm.
There are certain things that we do, there are certain tests that we do. Most infertility docs are going to do a lot of the same stuff, right? But it is so important that you connect with the person that you're going through this process with. And so if you ever feel like you're not connecting, and that's true if someone doesn't feel like they're connecting with me, then they should go and find someone that they do, because you're going to be with them through a very emotional time and a very stressful time. And so and this is to people that are listening, if you're out there and you're going through this process and you feel like you're not getting the answers that you want, you should go somewhere else and ask, because it doesn't mean that you need to go to another doctor necessarily, but you should just see if there's someone else that you mesh better with,
I know. Amanda walked into the waiting room and she goes, "Oh my gosh, I didn't have this experience in Charlotte." Like what? And that was literally just Leslie at the front, just like saying hi, knowing my name, knowing like my story and stuff. And it's just so different.
Yeah, I wish I would have sat down with you explaining all this a couple years ago, because I'm like, that is not what I experienced.
I just think it's really important. And I know that we're on the same page of this, and like, we kind of do the same thing. We want people to understand the why, why. For what, and I also will tell people when I don't know, like if I'm like, we've gone through this and we've gone through all the workup and it's unexplained, we'll say, we don't know, but it doesn't mean you can't get pregnant. Unexplained infertility is really common, but it's very frustrating.
For both Kat and I, obviously hers is like unexplained for recurrent loss, and mine is unexplained just fertility as like a whole.
Yeah.
But like, do you have, okay, so obviously I don't know if you guys know my story necessarily, but I had years, we went through multiple rounds of IVF, all very, very low AMH. And all of our embryos always were abnormal. We never had anything ever to transfer. We wound up finally doing like embryo donation, and we did all of that. But do you like recommend necessarily like any functional side of it? Because I also have an autoimmune disease. I have lupus. And so I'm curious with like people that also either have an autoimmune or like unexplained infertility, do you guys like suggest doing like side by side any like holistic practices or any kind of like functional medicine like acupuncture or other things? What would you say to someone who potentially has like those diagnoses?
Yeah, so I think those are two different categories, right? Like you mentioned history of lupus. Well, that's pertinent. That's clinically significant. I'm not a rheumatologist. I want to know what the rheumatologist has to say. I want to know what, any other, providers, functional or otherwise, might have to say. I try not to make what we do a cookie cutter approach, a sequential approach, it's my way or the highway, I'm all knowing approach. And there are those that are like that. I used to work for one in Dallas. There's plenty, especially if we get into the autoimmune, inflammatory related things.
I love that you're looking at me, because I do have to just bring this up. I will say that I don't want to tangent, but I brought, do you remember this?
Yeah.
I brought Dr. Tarnawa a whole folder. The reproductive immunology. Like for the two of you in the room, I don't know how you feel about it, but most REIs kind of are like, this is either quacky or it's not aligned. And I had brought him a whole folder. I had gone to the Derbala website, signed up as a new patient, and they printed out all these labs that I was supposed to have drawn. And I brought you the folder, and he went through every single lab and said, yes, no, or he said no, why he was saying,
that's
like,
amazing.
You probably shouldn't do it, but you like entertained me.
Well, Yeah, I
Which is
mean,
hard now.
Yeah.
but there are, especially if we get into the immunology world,
Yeah.
is the immune system important when it comes to achieving or maintaining pregnancy? Of course it is. The
Yeah.
problem is it remains a black box. It really does. We know enough to meddle. Okay. You can do some really non-specific tests. You
Yep.
can offer some really non-specific treatments, but I never lose sight of the fact that, you're in a vulnerable population. Usually when people are far enough down this road, if somebody says jump, you're going to say how high, right? Oh, I got the magic test, I got the magic pill.
Literally.
But it requires somebody to be objective, to learn to say when certain roads are worth exploring or not,
Yeah.
because there are many that are not without excessive cost, no benefit, and risk. That's a really bad combination, right? There's a really good commentary in Fertility and Sterility. That's one of our big journals, and they described certain practices like, hey, fly to the Philippines or Thailand and get some of your partner's blood and run it through your
Yeah, but yeah.
Stuff like
Yeah,
that.
sure.
It's like practices like that. That's an extreme example.
Yeah.
But also spending $3,000 on some lab panel that's not going
Yeah.
to change anything.
Yeah.
They describe that practice as predatory.
Mhm.
And a vulnerable population, people will prey on that.
Yeah.
And you have to be careful not to go down that road. There's not always answers,
Mhm.
like Dr. Tyson said. Sometimes we have to accept that. I'm willing to think outside the box within reason,
Yeah.
right? But not, but I didn't with you probably or other people. I won't support doing things that are associated with potential for harm or more frustration, confusion,
Yeah.
that it's unless there's consensus / expert opinion and guidelines that we need to do. And some of these things might get there one day, but a lot of them we just don't.
Yeah.
Unexplained infertility, you started to allude to it. I get it. Nobody likes that
The
term.
worst.
Nobody likes it.
Yeah.
It doesn't bother me. Okay.
Why? Why doesn't it
Yeah.
bother you?
Well, and this is what I tell everybody, because to me it equals options.
That's fair.
And in most people, it equals a favorable prognosis. Um,
Unless you know you're me.
yeah, well, I mean, but we go through that
Yeah.
process, and if we're not getting where we want to be, I mean, our thoughts change, we adapt, we
Sure.
adjust. But in most people, it equals options, and ultimately they have to decide how efficient do they want to be. So IVF, yeah, it is the most effective treatment for unexplained infertility. It does not make it the only one
Yeah.
by any means.
Sure.
No treatment's an option, right? If the tubes are open, you got sperm, those are the two gotta have them ingredients. Can't say that won't work. Maybe you'll be pregnant 7 months from now. If you knew, you wouldn't be here,
Yeah,
right? You
yeah.
just be trying. But we don't know. Some people are comfortable going down that road. What about IUI? Well, that adds some benefit over no treatment. But in general, and there's caveats and exceptions, but the likelihood of success with one IUI cycle is a lot different than IVF. Some people say, spare me the talk. What's the best you got? IVF, they do it. Okay, great.
Well, that's what you did with me. It wasn't like you said, your only option's IVF, which is what the first clinic
Yeah.
said. And both my girls are not IVF, but
Mhm.
you were just like, you seem like you're ready to go. You've been
Yeah.
through, I don't even know that time, 5 miscarriages. Like the most efficient way is let's do IVF. I
Yeah.
can test the embryos. We can control some things,
Sure.
but you were never like IVF's the answer.
Yeah.
Yeah, and miscarriage and infertility a little bit. I mean, absolutely different points on the same spectrum, but I approach those conversations in terms of options differently depending on which one we're talking about. But back to the unexplained infertility, yeah, some people straight to IVF, that's what they want to do. I'm good with that as long as we're not in a futile situation, but others are more comfortable with a stepwise approach. Let's spend more time, do some IUIs, see where that leads us, get together, talk about it if we're not there. Doesn't mean we have to divert after 3 cycles. That's
Yeah.
not set in stone anywhere, despite what others may say. There's room to keep trying, but it's just an opportunity to debrief. What do you think? What have we seen? Ultimately, I believe strongly it boils down to how people value efficiency, and that can change
Yeah.
with time, with insight, with repetitive, I don't like the word failures, but unsuccessful cycles, right? That can change. Some people say, I'm gonna do 10 IUI cycles, but as they do one, they're like, this is for the birds, it's
Yeah.
have some. So everybody's different. It doesn't have to be a one-way fits all
for
for
sure.
everybody.
Yeah.
And to also piggyback on what you had said, Graham, I want people to understand this stuff, understand what we're going to test and why, understand the options. How do they compare? Why is one different than the other? Kind of a quiz I have for people that have been to other places is, what's your AMH? What is AMH? You wouldn't believe the number of people that have no clue.
Yeah.
Like any test I do, we do. And that's why I'm so happy you're here, because we see the world similarly. I want them to understand what we're doing before we do it, to feel educated. That equals, that's the only way they can make informed decisions about which way to go. So really, in terms of what questions should they ask, anything that's necessary to make sure they walk out of here understanding where we're at, where can we go, what is the next step.
And like, essentially anything that we do is going to be, elective is the wrong word, but it should be the patient's choice, right? And so I always say that my job is to take the information that I have and boil it down so that they have this information in my mind so that they can make that decision for themselves. I never want to be the person that says, I'm making this decision for you, unless someone straight up says, decide for me.
Yeah.
Which every now and then someone will do that, and that's fine. But I think that the main job is to give people information so they are empowered and they have the autonomy to say, this is the right choice for me. I usually think, talking about unexplained infertility, the way that I typically explain this to couples, similarly to what you just said, that, when you have unexplained fertility, most people have been trying for about 12 months. That's the diagnosis, right? So by then, what I always say is that the chance of pregnancy is not 0, right? It's low though. It's like 4%. That's what the textbook would tell us, 4%. So if you
With
keep
no treatment.
with no
Yeah,
treatment,
yeah,
with no
yeah.
treatment, yeah. So if you're doing it on your own, you keep trying for a couple of years.
And doing it right too.
Yeah.
Yeah.
I was saying, like,
exactly.
I know
Yeah.
I tried for a couple months, but I didn't even know about ovulation.
Right.
Which is crazy.
Talk about that too. It's called
Yeah.
optimization of
Yeah.
natural fertility.
Yeah.
So, 4%. So it's not that great, but it's not 0. And so, you keep trying for a couple of years. And the data really suggests the patients will go and have kids with IVF. And then many of these patients will go on to have kids later on
So
after
many of our guests.
Yeah.
And that's why, because the chance is not 0, it's 4%,
Yeah.
right? An IUI is going to take that chance, is specifically in unexplained infertility, from about 4% up to 15%, right? So it's, for those people, like, that sucks. It's like,
And
it's not very good.
Is it like a fertile couple? That's probably not the right definition, but like, isn't like the average day on the street couple that's not having issues? Is it 20% a month?
20%. That's exactly my next point.
Yeah.
It gets you close to sort of normal human reproduction, which I say we humans are bad at making babies.
Yeah.
We're the worst species in the entire world at making copies of ourselves, right? We're bad at it. So this takes you from that 4% up to about 15, which is close to 20. And so that's why I typically say I think of 3, because at 3, and just as you said, it's not a hard and fast cutoff. It's whatever. Some people like to do 1. They're like, no, forget this, no more.
Yeah.
Some people will sit down and after 3 and say, you know what? Some people's insurance covers IUIs, but not IVF. They're like, we don't have the money for IVF. Let's do some more IUI cycles. But after 3 of these, for in couples that have unexplained infertility, we would expect that close to 50% of couples will have gotten pregnant and are moving on. And so that's why in my mind I sort of settle on 3, because
Do you see that in your practice that like some couple like it really like that 3 is a good for your patients?
Yeah, I do. And again, it's not quite 50%,
right,
but it's close. Right. And what I typically tell people if they don't get pregnant with 3 is just like with normal human reproduction. The first time you start trying to have a baby, you start at 20, right? As you try and try, that number is going 20, 15, 10, 4 until you get to see us, and then we're at 4%. The same thing is true with IUIs, right? There's a law of diminishing returns, right? Keep doing IUIs, your chance starts at 15. If you do 10 of them, your chance isn't 15 per cycle anymore. It's going to be a lot lower. And the other thing I say to people is, IUIs are a lot cheaper than IVF, but they're not free, right? Yeah. And so if you do 12 IUI cycles, eventually you'll probably get pregnant with them. But by then you would have spent so much money
and
so much time and so much failure and stress and just all that stuff that you might as well have just banked that, thousands of dollars and used it for IVF and gotten pregnant earlier and probably for less money too.
Yep. Yeah. Okay, so that goes to my next question, which I think is really like relevant in actually both of our stories, but a listener asked the question about balanced translocation. So that's like a legit diagnosis, right? So
Yeah.
like if I'm diagnosed with balanced translocation, what are my options? And I think that's where IVF kind of comes into play and similar to the time thing. So I'll let you guys answer that question and then I think get into more of like the PGT testing and
Sure.
stuff.
So, like Dr. Tyson said, humans are inefficient reproducers. And the reason for that is fairly simple. Each month, one egg ovulates. And at any age, any given egg is more likely to be chromosomally abnormal than normal. I don't like the term egg quality. I think it's unfair and points a finger, but that's the one we use, and that's what it means. How likely is a given egg to be normal? What percentage of eggs in the ovaries are after a an IVF cycle are normal? That's egg quality. And age is the biggest driver. Not great at any age, right? That's why it's 20% or so per month in a 25-year-old I'm never going to have to meet, because any given egg is more likely to be abnormal. So we're starting with a baseline high rate of those. A translocation happens in the earliest stages of development of that person who carries it. They are chromosomally normal people. They have all the chromosomal material that they need, but before the first cell division even, a piece of one chromosome and another broke off and swapped spots. So they have everything they need, but whenever they try to make eggs, or in the case of men, sperm production, where that chromosome number drops from 46, like all of our cells in our body have, to 23, which is what eggs and sperm have, all sorts of funny combinations can happen. So it takes that rate of abnormal eggs from here up way, 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 way higher, okay? So they have normal eggs. Men can harbor these things. That's one of the biggest places in the recurrent loss workup that it's incomplete, is not checking the male partner for with a karyotype to look for things like translocation. So there will be normal eggs, there will be normal sperm, but they are fewer and further between. Needle in a haystack's a reasonable analogy, not necessarily that extreme, but that also gets to, you got options, right? A classic history of somebody with a translocation is a combination of normal, healthy live births and miscarriages, right? So it can happen, but if somebody's having trouble achieving pregnancy or more miscarriages, what can we do about that? We can't go reprogram their chromosomes, but we can offer IVF because we have the ability to look for the embryos which are chromosomally unbalanced due to it versus those are not.
Can I ask a question?
Mhm.
So karyotyping would be the test, right?
Yes,
That would identify that in the people,
The
Correct.
parents.
Yeah.
in the parents.
Yes,
Yeah.
both of them.
And
all right?
because if you get a karyotype back, you can literally look at that specific chromosome. Is that right? So it gets
Yes.
very detailed.
And so that would tell you, in the case of a translocation, it's two particular chromosomes. It would tell you which ones you're going to see more abnormalities in the egg/sperm/embryo. So IVF, it can't fix the translocation. Another example is something called an inversion, but that's another similar but different. Yeah. Gosh, but we can identify embryos that were not affected by that. Now, by transferring such an embryo, we are controlling for the most important cause of a miscarriage, which is chromosomal abnormality. Those with a translocation would just have more embryos affected by that. However, that assumes one is present, meaning a normal embryo after IVF. We can't guarantee that.
So that's Amanda's story.
Yeah.
She did 3 egg retrievals,
Okay.
right?
Yep.
And you got what, a total of 6 embryos?
I think out of all 3, I had 9 is the total.
9
And
embryos,
after 3 rounds.
and they were
and every
all
single one.
abnormal.
And there was no like correlation. It was always like
So is
very different.
PGT, because there's 3 PG whatevers, right?
Yeah.
Yeah.
What's the right one to do?
For a translocation, technically it's something called PGT-SR, which stands for structural rearrangement.
Okay.
Before I dive into that, again, one option for that couple or individual is to, keep trying, right? Individual would need IUIs, but a couple can keep trying. It can get there. Again, it boils down to how efficient they want to be. But when it comes to the testing, PGT-SR will actually show which embryos have the translocation itself. PGT-A, which is kind of the standard, stands for pre-implantation genetic testing for aneuploidy, it'll still show the balanced embryos, the normal chromosomally correct embryos. It just won't say among those that are balanced / correct, which ones have the translocations versus which ones don't. Not a huge distinction.
Yeah.
And I've kind of I don't necessarily buy in hook, line, and sinker the need to do PGT-SR.
Yeah, I was gonna say 'cause
for
we,
that,
we
but-
identified there was a very interesting case for a couple who they didn't have recurrent pregnancy loss, but they had had infertility, hadn't gotten pregnant, right? So ended up eventually after time doing IVF. The person had a great ovarian reserve, ended up with 9 embryos. All of them were aneuploid, but they were all aneuploid in the same way, where there was essentially, I think it was a piece of chromosome 7 was missing or duplicated. And based on that, we were able to say, okay, there's one of these parents has something.
Did their karyotype come back normal before
That's
that?
the thing that's so interesting is they did. So the duplication or deletion was so small that you wouldn't necessarily see it on a karyotype. We even did something that's a little bit, so karyotype is basically like taking a picture of the chromosomes, right?
Yes.
So you like literally look at them under the microscope, and there's, I think it's software, but they basically Photoshop the ones that match to each other, and then they
And
line
they
them up.
print you out a report,
Right.
and you
Is
get to
it
look
the
at.
same as like just?
Oh, this is all of our listeners know. We ended up doing the high resolution
Yes.
karyotype.
Right.
Okay, so
Yep.
that's what I thought that was. So this is just like the
This is
regular
first round.
genetic
Yeah.
first when you're there.
So we did high resolution, still couldn't find it. Did a microarray, which is even more higher resolution than that, still nothing. But we
Wow.
knew just based on the
all
testing.
Results. Yeah.
And so, but we weren't sure, but I talked to this couple and said, hey, because the problem that we see is the same problem, the chances of you having a duplication, deletion in 7 over and over and over and over again is so small. Almost certainly one of the two of you has something going on.
Yeah.
So we did another round of IVF, and turned out the numbers lined up exactly with what you'd expect for what we're talking about translocations. They had another like 9 or 10 something embryos. 2 of them were normal, euploid.
It's just like a numbers game at some
Yeah.
point,
That's
right?
exactly right. It's a numbers game. Which is a really hard thing to have to wrap your head around,
Yeah.
right? It's like it's a hard thing.
Especially when you're talking about like in my situation, I say our situation because
Yeah.
you're my doctor. In my
Yeah.
situation with the loss piece, it's
Yeah.
like, for Dr. Tarnawa, he's like, maybe you should do IVF so you don't have to have 7 more miscarriages.
Well, that's exactly right.
And what's your threshold there?
Yeah.
And back to your case, Amanda, you said all those embryos that were abnormal. That's horrible, right? I mean, it's terrible to get that news. I know it was. Another way to look at it, right? And this is getting into, because I know people ask, PGT or not. There's there's some news stories out there right now about it, but imagine you hadn't, right?
Oh yeah.
Oh my gosh, the number of transfers and disappointment.
100%.
Right.
I was told not to test them
Yeah.
Because she was
I was
25.
25.
Yeah,
Exactly.
25 years
No,
old.
20. Yeah, I was 26. I was turning 26 that year.
Yeah.
And
so
I
was
used-
told not. That's like why I've been on like our podcast, and I know everyone obviously has different like ideas about it, but like I'm always like, just test it. Like you would rather I could have been sitting there for years still
Yes.
like
Yeah.
miscarriage after miscarriage
Yes.
because they wouldn't have worked.
And for Amanda's story, her very first IVF transfer with a donated embryo worked. She has a 3-year-old son.
3-year-old son.
And
Wow.
yeah, I mean, it was just immediate. Like it worked,
Yeah.
no issues, great.
Did they have any understanding of like did they think that one of the two of you had some kind of translocation? Was there anything like that where there was any pattern?
They did not even mention it. I had never even heard about it until
Wow.
Kat.
So when Amanda and I connected, I noticed very, very quickly, like
Yeah.
you were, I'm not saying left in the dark, but you were kind of just like, you can do another IVF egg retrieval. And you were in the efficient mindset of like, no,
I was like, I'm not doing this again.
Yeah.
I was like,
Yeah.
and then we heard about like embryo adoption, donation. I was
Yeah.
just like, yeah, I'm not going to do this. I'm
It's
just
a
gonna-
great option. We
Yeah.
have an embryo donation program here
Yeah.
that we run through PREG.
Oh, can we
Amazing.
hear about that?
Yeah,
Because
please.
Amanda has to fly to Michigan.
Yep.
And for every transfer, and
It's a whole process.
yeah,
Yeah.
yeah.
Yeah, I mean, embryo, and so some will call it embryo adoption. That's fine, but it's a wonderful option. It's helped so many people. It's an example of what we call third-party reproductive treatment. Donor egg IVF is another example. Using a surrogate or gestational care is another example. But there are some sort of entities out there that view it as an adoptive process. The word adoption has very specific legal and societal and privacy implications, right? ASRM, American Society for Reproductive Medicine, they feel strongly it should not be an adoptive process. It should be a donation. And so that's what we call it, and that's what we do. There are some out there, and I'm not saying it's wrong, but they do view it as an adoptive process where they basically can link you up, match you up with embryos anywhere in the country.
Yeah.
Well, our program, well, back to that example, these could be embryos from many years
Yeah.
ago.
Yeah.
Day 3
Yeah.
is frozen, maybe not
Most likely to succeed.
of exceptional prognosis
Yeah.
slash quality.
Yeah.
Here it's people have gone through IVF. They have met their family building goals. They still have embryos. What do we do with them, right? Well, one beautiful option is to donate them to other individuals, couples that need them. So any embryos that are part of that program here are going to be high quality. Again, excuse me for using that term, but embryos that look normal, that have met proper growth milestones. More and more and more have been PGT tested, which is great in terms of their per transfer per embryo prognosis. We have a waiting list. It's not long. I mean, I think it's 6 months or so, but people, once they match, they do it. They're happy. It's less expensive than donor egg IVF. And as big as PREG is, I mean, spanning really the Carolinas, I mean, we can help a lot of people through that program, and it's been a rewarding,
This
option to be able to offer.
6
Yeah,
months is
incredible.
not like even that long. And Amanda actually, if you want to share quickly, I mean, she matched on Facebook.
I did.
Mhm.
Wow.
And so a lot of our,
Family.
yeah, but a
Yeah.
lot of our listeners try to, they hear a story.
Yeah.
Hers was so incredible. She matched within like a week or something, and it was a really awesome outcome.
Yeah.
But then people come to her, ask for that Facebook, and I was one of those. I think I don't even know if you knew that. Like I was trying to go through all the different options. You don't get responses. You just feel like there's no light at the end of the tunnel.
for
Just
sure.
to know that
No, it's definitely a riskier way to go.
Yeah, I mean,
Obviously, you
on
know,
Facebook Marketplace, I
clinics,
can't even. I'm trying to buy
but-
like a desk right now. They can't even get in touch with anybody.
Yeah.
But yeah, it's just to know that that's an option and just
Sure.
have a light at the end of the tunnel of like they are there, because
Yeah.
when listeners hear like our stories and they're like, I have to wait for somebody to respond to me on
Well, and I
Facebook.
think there's something really important. I'm sure you guys have talked about this with your listeners before, which is I have so many patients who, when I start to talk to them about embryo adoption, egg donation, egg donors, they start to feel like, oh, you're giving up on me. This is like the end. And what I
Yeah.
always tell people is that is not the end. Building a family is not about your genetics.
Yeah,
we
no.
share like we humans share like not all of us share like 98 point some. We're almost all exactly the same as it starts, right? I tell people all the time, like Ryan and I, we used an egg donor. We chose not to know which one of us was the biological parent of our kids, right?
That's so cool.
Yeah. So I don't necessarily know if Quinn, my son, or Ada, my eventual daughter, is my biological kid. It doesn't matter, especially, and I tell patients all the time, like you also have the added thing that I don't get to enjoy of you get to actually carry this baby too. By the time you deliver that baby, it does not matter where that embryo came from. That is your baby. And I really, really try to talk to patients about that because, you do have patients who that is the best option for them, right? And they have killed themselves going through so much struggle, trying to like use their own eggs, trying to go through IVF cycle after IVF cycle after IVF cycle, when this incredibly amazing possibility is sitting there for them. So I'm sure that you guys have talked so that other people, other listeners out there know that, because like I say, it doesn't matter. You have this baby. That is your baby.
We always try to we've said it on previous podcasts of why, go get to your core why. Why are you trying to have a family? Is it to have a 9-month experience of pregnancy? Amanda really wanted that. I didn't. I have a horrible pregnancy. So for me, it was I would rather ultimately be 20 years down the line and be sitting at Christmas with this beautiful family
Right.
than to have foregone that because I just really needed to be pregnant for 40
Yes.
weeks.
Yeah.
And you don't know what that pregnancy is going to be like. I mean, mine have been horrific. So
Yep.
I would love to not have to do this personally.
And
Mine was a breeze.
Yeah,
And the thing about
yeah.
gestational carriers, if you are able to work with gestational carrier and that's the best thing for you, it can be an incredible experience.
For
Yeah.
sure.
I have our gestational carrier that we're working with. She carried Quinn, she's carrying Ada, and we're extremely good friends with them and their family. They're like a part of our family now, right? And I always tell patients when they're considering this, the baby will not remember who carried them.
Right,
That's
right.
so true.
If this is something that you need,
Yeah.
It's definitely
yeah, and there's nothing wrong with wanting that. It's like I said, it's a really important and an amazing thing to be able to do. But if that is not the best option for you, It's just like using egg donors. It's just like using donated embryos. It's just they're different ways to get to the same end, which is having a
Which
family.
is the
Well, we've talked about a ton of stuff today, and I love it.
I know.
I feel like you always still learn, and I feel like even in y'all's career, you're probably
We're
like,
always learning.
yeah, still learning every
Yeah.
single day. In terms of like IVF regulations, I know your clinic specifically has a really great IVF like lab. Some clinics don't have that, on site. What does that look like for PREG?
Yeah, so it's as you well know, if you do a quick Google on IVF, you'll come up with quite a bit of reading material nowadays. And it's unfortunate. It is. One thing that comes up, I think, time and time again, there are those who are misrepresenting IVF. They're after IVF, it seems like, unfairly, right? Because infertility is a accepted medical disorder for which we have a extremely effective treatment. And to try to limit access to that is cruel. It's unusual. It's trying to set back advancements in the medical field by decades, and it's unfortunate. One of the main things that some of these IVF detractors say is that it's the Wild West, right? Unregulated, unchecked. We're doing all sorts of weird and crazy things here in the US and look abroad for how they regulate. I can make a very strong argument, and the American Society for Reproductive Medicine has some bulletins recently published that will spell this out a little bit more. I argue there's not a more regulated field than what we do from a state level, from a national level.
Yeah.
We have state medical licenses. We are board certified, doubly board certified, right? We have to maintain those board certifications through staying up to date with, medical literature and proficiency exams. On a national level, there's not one, not two, but three federal agencies that have a keen interest in what we do and regulate us as such. The CDC are involved with, monitoring IVF success data. The Centers for Medicare and Medicaid Services, they oversee what's called CLIA, which makes sure that laboratories are functioning as they should. The FDA, right? Any drugs we're using, they have to be FDA approved. That's years worth of research. Also, we talked about donor egg IVF some. Anybody using sperm donation, egg donation, that is highly regulated by the FDA. They can walk in here right now in a full uniform and say, show us everything we need to see, and if we don't like what we see, you're closed, right? So we're constantly regulated and inspected for those things. Third-party payers, right? Insurance companies, they look at success, they look at outcomes, they look at multiple pregnancy rates. And to be able to participate, to provide services for their members, you got to do it right. And this day and age, so many advancements in terms of embryo culture, PGT testing, have reduced one of the biggest problems that there was in this field, which is multiple pregnancy, to something that's so uncommon. And we have now achieved extremely high degrees of success with negligible levels of complications of any type. And that's where the field's been trying to get to since this all started in late 70s, early 80s, and we're there. And to knock it back several rungs down the ladder would just be bad. So another argument I hear is that, it's unsuccessful and it never works and people spend, X, Y, and Z for no luck. I tell my patients, look, if there's a bad day, I never lose sight of the fact that this is their first foray into our world. We live in it, but that does give me the ability to understand how to counsel them through an unsuccessful pregnancy test or a miscarriage or an outcome they didn't want, that, hey, it can get better. Keep on. Here's what we need to do. And in almost all cases, we're going to get them there. Maybe in some cases it requires the third party options, which are beautifully effective also. And I say that if that wasn't the case, and almost every person that walks through this door, we're not able to get them where they want to be. If that wasn't the case, I would do something different.
Yeah.
I don't like those days either. I would not subject myself to that. So those are two of the most commonly things I hear is, oh, we're no good at it and we're stealing money and it's the Wild West unregulated. Wrong, wrong, wrong. Some of the religious organizations, right? Not all, but some have staunch disagreement with what we do. I remember before I went into this thinking, will there be situations that I find ethically concerning, challenging, unacceptable? It's never happened.
Yeah.
Like what we do is not that,
Yeah.
or it's not at all controversial. But people that write about it, that don't understand it,
Yeah.
a lot
Or
of
post a quick
politicians.
TikTok, and
Yeah.
it's like, but you didn't
Well,
need IVF to have the family.
Well, and I just looked
Yeah.
at something I just showed Dr. Tice an article, and I'm not even going to give merit to their publication, but a prominent one where they basically say, oh, why do IVF when we have these things that are so much better? And they spout off a bunch of unproven buzzwords like,
Mhm.
PRP and cortisol, and I look, who wrote this
Nonsense.
thank you, Dr. Tyson.
And they don't take into consideration people that maybe don't have a uterus
Exactly.
or
Yeah,
same-sex couples or things that like you anatomically cannot change.
Sure. And the person that wrote that article was a naturopathic
Of course.
provider.
Yeah.
Again, predatory.
Yeah.
Predatory, and it's taking advantage, it's false promises to a vulnerable population. And then finally, a lot of talk on let's call it mishaps or what have you in the lab. The number of cycles that occur annually worldwide, or if you look at the total number since the earliest days of IVF, the percentage of cycles, cases, events, steps taken in the lab that have resulted in medical error is infinitesimally small. Okay. There's an element of human error in anything, and there have been some prominent examples of that recently. Our field cannot be characterized by that. It is a principle of medical ethics that medical errors should be disclosed. If they happen, they would be disclosed. If they're not, there's no regulation that's going to fix that. But fortunately, errors like that do not happen. All right. And the ones that did were noteworthy. There's explanations. Hopefully they can improve and learn from that. But that is not what individuals exploring infertility or IVF should expect, because the team of embryologists in all of our labs, and we have 3, that helps to spread the workload out a little bit, right? And I feel strongly that helps, and we have data to support that. We'll limit that, at least in our hands. And I know every single other IVF provider in this country feels as passionately about it as I do. So I hope people are not nervous about our field due to some egregious events that have recently been highlighted.
And I think that the thing to keep in mind is that anytime something happens like that, it's going to make the news, right? So you're going to see that there's a bias towards seeing when things go wrong. So it may kind of give the impression that it happens more often than it does.
Right.
When what they don't go over is, well, this happened. There's millions of these cycles that happen.
Yeah.
And of course it's kind of like me. I'm a nervous flyer, right? So like I'm flying. Ryan says like, don't be nervous. It's like
I'm
you're still
worst flyer.
You're gonna. I'm still thinking about the plane crashing, right?
It doesn't happen.
But I do in the logical part of my brain tell myself, okay, it's really, statistically speaking, it's very, very unlikely. So it's normal to like read those things and make you anxious. But if you are anxious about that kind of thing, go into the back of your head and say, okay, hey, look, the numbers are with me on this. The chances of this happening are so.
Right.
And that's because we have multiple checkpoints along the way. Timeouts. The embryologist has them. We have them with the embryologist. We have them with the patients again and again and again and again to make sure that sort of thing doesn't happen. And so I know it doesn't necessarily quell all the anxiety, just like me riding in a plane, but you can tell yourself like the plane's not likely to crash. It's not, the numbers are with you on this.
Thank you guys so much for being with us.
Thank you guys.
This was incredible. We will share, maybe we'll share your TikTok.
Please do all 3 of my videos.
All 3 of your TikToks. We'll share the PREG website. We'll make sure that you guys can find them all in South Carolina and then the Asheville, North Carolina clinic as well. No virtuals, right?
Yeah,
you do virtuals?
We do virtuals,
Okay.
absolutely.
So yeah, look at our show notes.
I saw somebody from Stockholm, Sweden last week.
Oh, perfect. Okay.
Cool.
Well, our podcast, I think it's reached like 88 countries.
Wow.
It's incredible.
Congratulations. That's awesome.
Yeah, it's super exciting. So if you're listening from Russia, which is one of them, which is crazy,
So crazy.
Japan, Thailand, well, maybe we can get some crazy virtual visits on there.
Yeah,
But thank you guys so much.
I know.
Awesome. Thank you guys.